decrease stress, get rid of friends that are pissing you off, minimize relatives that are making you mad or angry or stressed out. We've got to get people to Zen.
Welcome everyone to the Bob and Brad podcast. Today I am joined by Dr. Michael Okun, who is a board-certified neurologist and the director at Norman Fixel Institute for Neurological Diseases. Thank you so much for joining us today, Dr. Okun.
Yeah, it's my pleasure to be with you, and thank you so much for having me.
So we are going to be talking about Parkinson's disease specifically on this podcast, but the first question I have for you is, would you mind telling us a little bit about your background?
Sure. So I'm a neurologist. I work at the University of Florida, which is in Gainesville, Florida, up in North Florida, about 2 hours north of where Disney World is. And I'm the director of an institute called the Norman Fixel Institute for Neurological Diseases, and we focus on providing a comprehensive care experience for our folks who have different neurodegenerative diseases and neurological diseases. And we mostly focus on people who have Parkinson, but we also see, Alzheimer's disease and dementias, other movement disorders, ALS, sort of things that are in the family. And some people hit their heads and get some degenerative changes in their brains from that. I love history, love baseball. I have a bachelor's degree in history, and I've served as the medical director and medical advisor for the Parkinson Foundation since 2006. And Ray Dorsey, Bastian Bloom, Todd Scherer, and I wrote a book called Ending Parkinson's Disease, and there's a sequel book coming out in 2025. One of my passions is helping to educate folks who have Parkinson and their families, and anything we can do to impact lives. And by the way, I also do a lot of research, and so thank you to the federal government for funding my research studies for over the last 20 years, the National Institutes of Health and several foundations and other sources. And so we do a lot of work on, new things, new technologies, devices, implantables, and I've done quite a bit of work in the space of Parkinson's disease. So it's just a pleasure to be on your podcast today.
So who's your favorite baseball team?
Oh, it's a loaded question. Okay, so I just went to game 5 of the World Series.
Oh.
It's the only game the New York Yankees won. My dad sold peanuts at Yankee Stadium when he was a kid in the 1940s, and they would line the kids up outside Yankee Stadium, and they would choose the biggest and the toughest kids. And if you know the Okun clan, were kind of small, short, and clumsy, and so he would only get selected, for the Black Yankees and the Negro League teams that were there, and so he was selling peanuts when Satchel Paige was there, and all of those players along the way. And so he lived, maybe 10, 11 blocks in the Bronx. And but I grew up in Florida, and so the two teams that trained next to the area where I grew up was the Braves. So I love the Braves and the Expos, who were in Montreal at that time.
Okay. I'm a Twins fan, but I live in Minnesota, so that's why. At least it's our only team that's won a championship in this state. Anyway.
Yeah, I have Kirby Puckett's autograph when he almost got suspended out of the game for, you're not supposed to sign during spring training games. But I threw my ball to him over the center field fence, and he signed it behind his back and threw it back. So he's a great guy.
Ah, interesting. Anyway, where can people find out more information about you online if they want to contact you?
So I'm pretty easy. I work for the state of Florida, so I'm a government employee, and so you can pretty much Google me. I'm an open book. At Michael Okun is all of my social media presence for the Parkinson Foundation, for the Fixel Institute, and we have a nice conversation going on Twitter, now known as X, Instagram, LinkedIn, all the different platforms. And of course, if you want to reach out, at fixel.org is where I live at the University of Florida at this institute here, which I think is a super special place for folks who have Parkinson, because when we founded it, Kelly Foote, the neurosurgeon, and I, 20 years ago, the idea was person with disease is the sun, and we all orbit around the person, and that's in all missions. And so we have had that philosophy, and it makes it really a special place, hallowed ground, we call it, for the people that come here. So we're very blessed to be here.
So, could you tell us a little bit of information about the book you've written and where people can find it?
Yeah, so I've been involved with about 14 book projects over the years. I just turned in the 15th one, and so I'm a writer at heart, and so I love to write. I think the book that garnered the most recent attention was Ending Parkinson's Disease: A Prescription for Action. That book was all about, first we delved into, what does it take to cure a disease and to change the trajectory of a disease like Parkinson's. So we studied polio. By the way, this was before COVID, and then COVID came out, and so it was kind of an interesting exercise because everybody suddenly knew all about polio and what it took to cure polio. We studied HIV, we studied breast cancer, and we looked, on what we need to do, and we came up with this formula, and the formula was prevent, advocate, care, and develop new treatments. And so it was called the PACT. And the PACT is what we need to do to be able to move Parkinson's disease forward. And we offered a lot of tips, a lot of things about directions that we could be going. And one of the most awesome things about that project was it just inadvertently sparked a grassroots movement. A group was forming and formed around that time called the Parkinson Disease Avengers, led by Larry Gifford and Soania Mathur, and a number of folks were getting together and beginning to think about this, and they embraced that kind of as their cause. And so we have been involved in a number of different things over the years, including flooding the White House with 20,000 red cards in our red card campaign to call for an end to specific pesticides that we know are associated with Parkinson. We should prevent the preventable. We wanted to make sure telemedicine stayed available for our patients, particularly over state lines. And guess what? They didn't heed that. And you can see we lost some ground on telemedicine, but hopefully we'll get it back. We've been fighting a long time for how that's defined and to make sure people get access and we bring care to them. And then we have fought pretty hard for increasing funding by 10 times. And the title of our book has a very close title to the law that was just passed, 407 to 9 in the House, unanimously in the Senate. So if people think we're not bipartisan, we can be bipartisan about Parkinson's disease. And so the Ending Parkinson's Disease Act by the Honorable Gus Billy Rackus and is named for his brother and Jennifer Wexton, who has PSP, one of the representatives. And so it's really terrific, and hopefully it will set our folks on a plan here, because we need a plan if we're gonna move forward and move the needle on this disease. And so yeah, it's been a good journey. Well, we're just starting, and we got a long way to go, Mike. We got a long way to go.
So, when's your new book coming out?
So we've heard from the publisher. It looks like August in 2025, somewhere in summer of 2025. If it was up to us, it would be tomorrow. But we don't control the production costs, and we're happy not to be kicked out of the room. But we're going to be talking all about that plan and what we need to do, and then things that people can do, for themselves, but also things that we can do on policy levels, and how we need to change the way we're thinking, the types of things that are going to be exciting, and where we need to kind of take stock and reorganize, rethink, and retool our approaches.
So, the rest of my questions are all based around Parkinson's itself. So, we'll kind of get into that now. So, the first generic question is, what is Parkinson's and how does it typically progress?
Yeah, so Parkinson's disease, we kind of classify it as a degenerative syndrome. So what is all that googly gobble coming out of his mouth now? So what does that mean? That means your brain and different parts of your body, they have cells, and those cells are connected by pipes, and there's lots of connections that are sending messages from one area and one region to another region. When we say a disease is degenerative, like Parkinson's disease, what we're saying is that some of those cells and some of those pipes and some of those connections are beginning to either fade off, die off, or become damaged over time. And that's what's happening. And one of the things that people don't completely appreciate, and I know a lot of people who are listening to this already know this, but I'm going to say it anyway, just in case, maybe we hit a few people, in your listenership. But, we assume just by what we hear in the lay press and everything that Parkinson is just a loss of a chemical in the brain called dopamine. And people know that because, there are all these famous pictures of people, the movie Awakenings with Robin Williams, and give dopamine, and you have this miraculous improvement. We know now that Parkinson is not just about one chemical, it's about multiple circuits. And so you can imagine there are multiple islands all over the brain. Those islands are working in parallel, and there's multiple circuits that are going and degenerating at the same time. And so that's one of the challenges, Mike, that we have in a degenerative disease is it's not just one area. So even as, everybody 20 years ago was thinking, oh, we're going to cure this thing with stem cells, and we're going to make a dopamine stem cell, we're going to stick it in the brain. Here we are 20 years later, and we're still struggling. It's because there are multiple circuits involved. And oh, by the way, it's a whole body disease. It ends up in your skin. You can see changes in your stomach, in your gut, in your nose, in your nasal passages, and so forth. And so it's a degenerative disease. The cells are dying slowly. Okay. And there's many different subtypes, and folks may not be aware that Parkinson's disease isn't one thing. It's actually a syndrome, and less than 20% of people have a gene for Parkinson's. That means 80% of people don't, and it's not just one thing that can cause Parkinson. And we're still learning all about this, and so it can't be a one size fits all. It's a complicated picture, but the challenge is there. So bring it on. We're ready to try to see if we can unlock some of these mysteries.
So, how do you go about diagnosing someone with Parkinson's? And is it easy to diagnose them early on, or is that kind of challenging?
So the diagnosis of Parkinson's disease for many years, even up to the present moment, Mike, might surprise you. It still, lives within the realm of a good examination by somebody who has some expertise in the area, and they give them some dopamine, and they see how do they get better on the dopamine, what gets better, what happens to them. That sounds a little rough around the edges, but you know what? That's kind of where we are, in the field and where we've been. Now, what we need to be doing is thinking about could there be some biological way that we could measure Parkinson's disease, and we could, decide, okay, somebody has Parkinson particularly early as we develop treatments where we may want to intervene earlier. And so that's where you've seen, the emergence of a whole bunch of different things. And so we see the emergence of images. So pictures of dopamine transporters. So these are called the DAT scan, okay? And looking at how that might be different on one side of the brain versus another. How about old-fashioned MRI scans? Everybody says those look pretty normal in Parkinson, but now we're feeding those through AI algorithms and finding out, wait a minute, not only can we see Parkinson, but we might be able to tell it apart from things that look like Parkinson. We call those mimics, when something looks like something else. And so that's another, sort of, pothole that you can step into when thinking about diagnosis. And so we examine, we give dopamine, we can scan the brain, but now there's also looking at blood tests and the fluid that bathes the brain and the spinal cord, and biopsies from the skin. And we can look at, these types of inclusions that include different types of protein. And I don't want to spew too much googly gobbly, stuff all over your podcast, but alpha synuclein is one of the proteins we look at a lot in Parkinson's disease, and learning how to measure that can be useful. So we're actually beginning, Mike, to crawl. At first we were crawling, now we're walking, and now we're actually running toward that era where we're going to be packaging a whole bunch of these things together. It's going to help us to diagnose. And now imagine if you live in a country, or how about in a part of this country where you don't have access and you don't have an expert. And it takes an expert to look at you. And by the way, you don't want to look at somebody once with Parkinson. You want to be looking at them multiple times, so that you can be sure a great doctor or healthcare professional is going to keep examining that person, see what happens to them, make sure they actually do have Parkinson. It's a tricky disorder, and you can be fooled, and you got to have it right to have the treatments aligned correctly. And so once we can prick your finger and do a little bit of a blood test, or use some of the imaging techniques like MRIs that we're using all the time, this is going to be a game changer for different countries and for different areas where there aren't Parkinson's specialists, and one thing that might surprise you in my role as medical director and advisor for Parkinson Foundation, it might surprise you, Mike, to know that in the United States, we're only training about 40 or 50 of these a year. That just ain't going to cut it, like, so we've got to begin to improve our diagnostic capacity, teach more people, bring more folks into the fold, train more neurologists, and also get our geriatrics medicine and other colleagues on board in this diagnosis journey.
Yeah, I recently worked with a patient who they weren't sure if he had Parkinson's, and yeah, all they did, as far as I'm aware of, is give him the dopamine pills, and he took them for a while, and then he was off them, and they claimed he didn't have it, but he acts like
Yeah.
he does, so I see how it's tricky.
It can be tricky, right? And not only that, what adds to that confusion for your friend or for the person that is that one opinion is just one opinion, and that's why I always say be humble. Every day I practice medicine, I know a little less. I'm a cabinet advisor to everyone. I never try to make anybody do anything that I suggest. Right? We work together. We walk the journey together. There's an old Chinese philosopher, Lu Xun, Mike, and he used to say there were no roads until men and women walked on them. And I believe that's true in Parkinson. We have to walk that road with people and see where it goes, and we can be wrong. And we've even told people like your friend sometimes, oh, you don't have Parkinson, and they end up having Parkinson. Or they get one of these, new modern tests and it says they didn't have Parkinson, but then a year down the road, they do the test again and they do have Parkinson. And so listen, I think we all need to just take a deep breath and be humble, as we're moving down this journey and make sure that we get it right. And there's an old Latin phrase called "Cui bono," for whose benefit is it if we rush, So let's get this right.
So, how much do genetics influence Parkinson's?
So genetics, you might be surprised, shocked, dismayed to know it's less than 20%. And so, it depends on which geneticist you read, and, but, like on maximum, it's going to be 1 in 5, probably a little less than 1 in 5, has a single DNA abnormality that we recognize is causative, meaning that it causes something. Now, everybody's getting genetics now. It's like the new thing. You get your genetic report. It's like, in Star Trek, there was the tricorder. They scan you, and this is what you have. It doesn't actually work like that in real life. And here's the other, kicker, for Parkinson genetics. And for anybody thinking about getting genetics, just remember this one thing. A lot of the Parkinson's genes, you can have the genetic abnormality, but it doesn't necessarily mean you have Parkinson's disease. Okay. So it's called penetrance. And when Mendel, Gregor Mendel, who was a monk who sort of is considered the father of genetics, was doing this, he was crossing pea plants and making different color pea plants and things. He didn't conceive of the idea that you could actually have a gene and it doesn't express, or it can express later in life. So what does this mean? This means that if you get your genetics done, Mike, and you have a Parkinson gene, like GBA, okay, and people talk about the Gaucher's gene, glucocerebrosidase, okay, another godly Google for your group here. Okay, if you get that gene, only 10% penetrance. And 10% of the people, so you go to New York City, a lot of people have this gene, okay, in certain neighborhoods of New York City, okay. The LRRK2 mutation, okay, very common in Ashkenazi Jews and Berber Arabs, okay, 30% penetrance. So you have to be really careful, and we don't know, what turns these things on. And so I think one of the areas that working with Ray Dorsey and writing with him for many years and collaborating on research, Ray and I talk about this and have bantered this a lot, and he's been a really big voice and advocate for the environment. Environment must have something to do with these cases, particularly when you don't have any history, any genetic history at all. Your genes look pretty good. Or it's some, modulation between gene and environment. And so when people hear experts talking about the environment, that's what they're talking about. They're talking about, are these pesticides, organochlorines from dry cleaning, things that we're spraying on golf courses and on your kids, sorry to scare you, but on your kids' playgrounds? Are these things leading to ALS and Parkinson's diseases, bad air, leading to this? Could you have built your house on a plume of trichloroethylate that's coming up from the ground because somebody spilled chemicals and they got into the supply and it actually comes up and out and you're breathing it in and increasing your risk? And so, so how much is genetic? Not as much as we would imagine, Mike. And even the cases that are genetic, it might be the environment that is showing whether or not some of those are turning on, because just because you have the gene doesn't mean you're going to get the disease. So one last thing for people that are listening, I'm going to give a great pitch for genetics counselors. We have two of them at the University of Florida at Fixel. We cover them through philanthropic donations from folks because the American healthcare system doesn't provide these. But how great is it to sit with somebody who can explain to you your genetics, explain your risk, and then you can make a decision. Do I want to get my genetics, tested or not? Do I want my kids to get genetics tested or not? To me, these people are heroes. They're underutilized, and we'll realize it as more and more people get genetics and get confused and depressed and dismayed and not sure how to interpret it. And so I find them to be superheroes in the modern healthcare profession. And so I hope we mint a whole bunch more geneticists and genetics counselors to help people to really think through these things.
Have you been genetically tested for it?
Good question. I have not had genetic tests, and so early in my career, I used to take a trip, and I was invited to go on a trip to a place called Venezuela, a country that you can't go to now anymore if you're an American citizen. Took the last trip with the National Institutes of Health there to study a disease called Huntington's disease. Maybe like a distant relative of Parkinson, affects many of the same brain systems we call the basal ganglia. And those people get a dancing disease that looks like the dancing you get from the dopamine, the dyskinesia, interestingly enough. And if I show you two videos of them, and I don't tell you who has Parkinson, who has Huntington's disease, you won't know the difference. We often do that to our students just to show we're smarter than them, if they're a little bit of humbling. But here's the point. When I was taking that trip, Mike, a long time ago, there's a very famous woman that ran that trip through the National Institutes of Health. Her name was Nancy Wexler. Nancy Wexler's family started the Hereditary Disease Foundation, which was a foundation that was founded in order to try to find treatments and a cure for Huntington's disease. And it was through her father, and they were close with Guthrie, and there was a whole history, a whole really fantastic history. Now the two sisters, Nancy and Alice. Alice was the historian. One sister decided not to get tested. The other sister decided to get tested. And this led to a lot of really famous writings in the literature, because when the Huntington's disease gene was discovered on chromosome 4, everybody thought, oh my gosh, Jim Gusella looked at all that data coming out of Iowa and coming out of Maracaibo in Venezuela, where these trips were going. They figured it out. They found the gene, Mike, and they said, oh, we got the test. You want to be tested? So you just ask me, have I been tested for Parkinson's genes? No. Do you want to be tested? Well, it turns out once you talk to a genetics counselor, once you know about penetrance of genes, whether it's complete or not, and in Huntington's it's complete, but it always happens in the majority of people later in life, half of the people don't want to get tested once they get genetics counseling. And so that's why I think it's super important. So at this moment, I don't really want to know. I want to live my life how I'm going to live my life. The problem I have is, let's say you and I both got tested and one of us had one of these Parkinson genes that's not completely penetrated. It's not going to change the way that we live our life, and it may never manifest itself. Am I going to sit around and worry about it, or am I going to change my lifestyle thinking it might change it? So there's a whole bunch of considerations you've got to kind of think through. So it's a great question. So the answer is no. Have you been tested, Mike?
No. The only reason I kind of know about this is because I interviewed a guy out of Madison. He runs a podcast called Dementia Matters. He's more into dementia and Alzheimer's. And he was talking about genetic testing because his father had it. And he asked me if I would get it. And I was like, probably not. I was like, I think I just want to, whatever ends up taking me in the end takes me. I don't want to know what it is.
Yeah, and I think at different stations of life, Mike. So, like as you go through life, you want to make those decisions as informed decisions. You want to think about, like what are the things facing you in this life at this moment in time. And right now, at this moment in time, I don't need to know whether I'm going to have a gene that's going to turn on later or not. That's not going to help me right now, with my life and my kids, and so I choose not to do that. Now, somebody else might say, you know what, I want to be as proactive as I can. I want to know, and then I want to start to try to change diet, exercise, and play the guessing game as to these things you can do to change your lifestyle. And that's totally cool. And I have a lot of people that do that. In fact, I saw somebody yesterday who doesn't have Parkinson but has one of those prodromal features. One of those either lost their smell or acts out their dreams or gets very constipated, and they're wondering, hey, do I have Parkinson's disease or not? And even if I don't, and there are no symptoms, should I be doing something a little different? And so it does inform the conversation. So I think these things are really important to talk about.
So, speaking of symptoms of Parkinson's, what are some lesser known symptoms?
Yeah, so we automatically assume everybody with Parkinson disease has a tremor. 1 in 5, that's 20%, don't have a tremor. Okay, so that's the first thing, and it's actually pretty interesting. Got an email from a really well-known colleague who's not in Parkinson disease specifically, saying, "Hey, my friend was told by their doctor they don't have Parkinson because they don't have a tremor," and answer, well, not so fast, as Lee Corso and Sports Center says, not so fast. Like 20%, 1 in 5 don't have to have a tremor. That's one thing. Second thing is some folks will actually have these dystonic postures. Their hands may cramp, they may not swing an arm, and the arm comes up where the muscles are fighting against each other. Sometimes we see young people, particularly with genetic, abnormalities and genetic forms of Parkinson, who can be very dystonic. And dystonia means muscles kind of fighting against each other. One muscle has to contract and another relax to make a movement. Like if you're doing a curl in the gym, your bicep has to contract, your tricep has to relax. If those two are co-contracting out of sequence, you end up in these abnormal postures. And so dystonia is another one that people don't think about. The handwriting getting smaller. A lot of people think about that, but not everyone. Freezing up, like when you're walking, and the freezing may not be on both legs. Usually it's one leg, and that's what causes you to fall, is one leg you freeze and then you're trying to turn over that leg that's stuck, right, and you fall. Another thing folks may not know or fully appreciate is the mystery as to why in almost all cases it's asymmetric, meaning it's never equal. So it's always a little more on one side than on the other side. And so we think about that, and a lot of scientists, a lot of good, smart people haven't figured that one out yet. And so I think those are kind of some of the things that we think about. And then, of course, these what we call prodromal, or features that are early features. Again, smell, if you lost your sense of smell, if you are acting out your dreams, the REM sleep behavior disorder, or you're getting a lot of constipation. And then finally, I would say that remember that some folks can present with neuropsychiatric abnormalities. What is that gobbledygook he's talking about? Depression, anxiety, particularly midlife anxiety that comes on suddenly, higher risk of Parkinson's disease, and studies being associated with that. So depression, anxiety, and apathy. And so we have to watch across, this spectrum of things. And I remember being at the White House with Ray Dorsey, and they were doing these champions of change for Parkinson's disease, and we each got to make comments. And one of the comments that I made was quoting another one of my colleagues, named Anthony Lang at Toronto Western University, saying Parkinson's disease is probably the most complex disease in clinical medicine when you consider all the motor features, tremor, stiffness, slowness, rigidity, et cetera, all the non-motor features, depression, anxiety, sleep, et cetera, okay? And response to medications and response to surgeries like DBS and all these things, and that changes and progresses over time. And oh, by the way, you get dyskinesia, motor fluctuation. So show me another disease that does that, and show me a disease that responds to dopamine and all these therapies like Parkinson over time. It's pretty complicated, so I think people should know that not everybody looks the same, and there's so many different symptoms, and they can emerge at all different time points across the lifetime of the disease.
Sure. So, how does Parkinson's affect mental health over time?
So it's an interesting question. In general, what we see is higher rates of anxiety, depression, and demoralization. Demoralization, the third of that, is one that we have not appreciated enough, but it turns out that about 1 in 6, 1 in 5 people get demoralized, and they may not be depressed, and they may not have cognitive dysfunction or thinking dysfunction. Apathy is probably more common than all of them, and so developing apathy. And then when we prescribe things like serotonin reuptake inhibitors, which are great for Parkinson, we need to be more careful when we're addressing these, because it's so common. The majority of people, need to have treatment. If we go too high on the treatment, we can worsen their apathy. Okay, so if you go too high on these serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors, Prozac is the plain one, the one that also makes epinephrine more available. Things like venlafaxine, people may have heard some of these types of names. And so we need to go low, we need to go slow, and we need to follow people. And when we start on treatments, for these, they're so common. We need to be thinking really about our plan. Where are we going with this? And we should not be putting people on it and saying, hey, I'll see you in 6 months, Mike. See you in a year, Mike. No, these should be like, I should see you in a few weeks, and we should be really monitoring you. We are now recognizing that midlife anxiety, may be more of a risk factor. There's some data coming out on that. And so recognizing, people that are suddenly getting anxious that weren't anxious before. And then the other thing that is really, just kind of mind blowing is when the medications are wearing off as the Parkinson disease progresses, you can get depression, anxiety, and all of these symptoms as part of the wearing off along with the motor function. And some of our folks have been going to the emergency room and being like, oh my gosh, I'm short of breath and I can't breathe and everything. And it certainly it could be something with shortness of breath, but it may actually be that we're completely missing anxiety, and they keep going to the emergency room. And what we need to do is we need to adjust their medications, optimize them to treat these things. The non-motor features across the board in most cases are usually more disabling than the motor features. Let me say that again. The non-motor features like depression, anxiety, apathy, demoralization are way more disabling than the tremor that you can see. And so everybody's thinking of the tremor. Even the healthcare professionals are thinking of those things. We need to train them to think differently.
So, how does lifestyle changes affect Parkinson's, and what are some things you would recommend?
So, I'm big into lifestyle changes. One of the reasons is I've studied Parkinson's circuitry my entire career, learned it from Malin DeLong, who just passed away this past year. One of the greatest, people in Parkinson, won the Lasker Award for all of these circuits in the basal ganglia. And we know that stress, anxiety, and sleep deprivation make the Parkinson's symptoms worse, Mike. Stress, anxiety, sleep deprivation make it worse. So guess what? What do we need to be focusing on? Decrease stress, get rid of friends that are pissing you off, minimize relatives that are making you mad or angry or stressed out. We've got to get people to Zen. And I am sort of well known in our clinic here for telling people Zen, live a life of Zen. Okay, is super important. I pay a lot of attention to sleep, helping people to get tracking devices for their sleep, whether it's a ring or a watch or phone. I got tracking devices all over me. Okay. And the idea here being, can you get people to be sleeping 6 to 8 hours a night, not just in bed, but sleeping? That's going to help their Parkinson's symptoms. Living Zen, sleeping better. And then what do we know about diet? Not as much as we should. There's a whole nutritional overreach, like where people say, oh, Mike, you got to do this or you have to do that. And we actually don't have the data. We still don't understand how yet to use the microbiome. I'm super interested in it. Collaborate with a lot of people doing research, but I don't want to overreach and tell people what they can and can't do or have to do. We do know that the Mediterranean diet, there's some data supporting that. There's some data maybe supporting this MIND diet. And you have to look at the difference between risk of getting a disease, and then once you actually have the disease, you also have to live a good life as much as you can. And but all of these factors I think are important. What's more important than the specific diet? So everybody spends all their energy talking about the darn diet, Mike. Okay, and what should they be talking about? Staying 5 to 10 pounds over your ideal body weight. I stress that with my folks with Parkinson because you slowly lose weight over time. So you want to always tell them, look, I want you a little bit heavier rather than a little bit lighter. That's going to help us long term. And screening bone health. And even men, and it's a male predominant disease, doesn't mean women don't get Parkinson, but more men than women. Even men get osteoporosis with Parkinson. And it's not just from them not moving. There's something to do with the brain circuits that get involved here. And so screening every couple of years, even in men, every year or two, maybe every year in women, really watching, for bone health, because with the risk of falls, you want to keep your bones healthy. So being preventative, man, I just can't tell you that those things are really important. And I recommend 7,500 steps a day if you can do it. And of course, if you have problems with balance, then you want to walk with somebody. That would be like 4 20-minute walks a day if you can do it. Not everybody can do it, and we don't want you tired the next day. But working your way up, exercise is like a drug, for this. And for people who can't do that, recumbent biking or other activities, even sit and fit types of regimes, and spreading it out, and trying not to win it all in one session during the day is so important. But being active is important not only for your health, but it's important for Parkinson, and it can reduce your symptoms as well and increase your Zen quotient. So those are just some of the secrets and things that I think about.
So, what new treatments or therapies are showing promise with Parkinson's?
Yeah, so this is something we've been writing a lot about. And, so we've written a number of books. And so over the years, we've looked at this. And of course, the book we have coming out in 2025, we look across a number of different, buckets. We think about near-term therapies. What can we do with the things that we have now? So repurposing certain drugs, okay, maybe things that reduce inflammation or reduce areas of the brain and other goggly, word, inflammasome, these things that are inflamed, and can we change those types of things with drugs we already have on the shelf that are already FDA approved and we should be using? Could we develop new targets and new drugs and try to get them, instead of in 15 years, try to get them to people, within 5 years? Making the pumps, the pump therapies, both for the stomach and now under the skin, making those more available, better, easier to use. So trying within the next few years to improve the symptomatic therapies across the board. Same with deep brain stimulation, focused ultrasound, and those things. So the near frontier, okay? And then when we have sort of the mid and the long range frontiers, the way I think about it, Mike, is you've got three buckets, okay? Bucket number one is powerful symptomatic treatments. Bucket number two is can we find things that are going to slow down the Parkinson's disease progression? Bucket number three is precision medicine. Could we precisely go after somebody maybe with a gene abnormality and really, grab that, disorder and take it down? The bucket for cure that people get promised all the time is a very tough bucket in a disease like Parkinson's disease, but if you think about it, if you can slow it down or you can personalize the treatment, we may then give the honors to cancer or something else, or to heart disease. And so figuring these things out, I think, is important. In terms of what we're thinking about kind of in the midterm, our diet's important. How can we change our microbiome? How does the microbiome affect our brain function and our function in general? We're thinking about gene therapies and reinventing gene therapies, thinking about regenerative medicine approaches, particularly for things like memory disorder, and looking at some of those systems. And some of the big words are basal forebrain. That's where some of our thinking, happens, and it's really important, sort of unaddressed. People that are falling unaddressed at some point as disease progresses. So falling, walking, talking, thinking, these things we need to develop specific therapies. And so there's work going on, across that spectrum. And then gene editing and gene therapies. And how are we going to do it? For who? For which disorder? For which types of genes? And also, could we use that information to actually understand where Parkinson starts? And so one of the tricks to the answering your question is this: if we don't understand Parkinson and we don't understand the why, then how are we going to get to rational therapies pretty quickly? And so in our new book, we talk a lot about this, how we have to understand our why. We have to look upstream, meaning early changes that are happening in the brain, and the zenness. We talk about the zenness of the person. Now, Mike, let's talk about the zenness of the cells in your brain. We call that homeostasis. How do we keep them zen, and keep the brain from degenerating? And we have to look upstream. Okay, when we say look upstream, that means we're looking at all these things that have already happened. These plaques get on your brain, like plaques get on your teeth. We try to clear the plaques off, and we say, oh my gosh, we maybe got a little benefit, but the Parkinson is still there. So in Parkinson and Alzheimer's and degenerations, we need to be shifting our thinking to look, more upstream. So thinking about near-term frontiers, some midterm, and then some of the long-term thinking, and thinking about why, I think, is going to be really important.
So you mentioned deep brain stimulation a little bit in there. Can you discuss what that exactly is and who's a good candidate for that?
Yeah, so in very simple terms, a DBS is a therapy where we put it's almost like a straw, like a tiny straw into the brain, and we can push electricity in. Okay, so we're not pushing chemicals or anything through it, but we're lighting it up. It has a little wire inside of it. We light up the areas of the brain, and what we have learned is the brain is a group of circuits, Mike. And so if we put that in there, there's different conversations going on between different brain regions. And if we choose some of those islands and we say, hey, if we change the conversation between these islands, the entire brain network changes its conversation. And guess what? A lot of the symptoms get better for Parkinson's disease. And so this can be a very powerful therapy. It can be done on one side of the brain, can be done on two sides of the brain for some folks that need it. And the things over the years that we've been doing, and our lab has been engaged in these types of studies in DBS, you probably know, for many, many years. And Florida is well known, for this, as are many other labs and centers around the world. But what we've all learned over time is choosing the right patient is really important, or choosing the right person with disease. We shouldn't say patient, and that we like to see good responses to medication. So that may seem counterintuitive. So we always give them a little dopamine, see what responds. That helps us to predict what's going to get better. It improves off time. Okay, so that time you're not feeling good, you may be tremulous, stiff, slow, rigid. It improves going on and off. That's the yo-yoing in a Parkinson person between feeling off, tremor, stiff, and slow, and then two on, where you're getting these dance-like movements called dyskinesia. So there's on-off fluctuations and motor fluctuations do really well with this. If you have tremor, that does well, and dyskinesia, these extra dance-like movements. If you have things like walking, talking, and thinking, those things, with the current versions of what we have for DBS, don't tend to get better. Although there can be specific tailored circumstances where some of those might get a little better around the edges.
What are your thoughts on, I believe it was called Neurolink? Listened to the interview with the patient that has it. Is that something that can go into Parkinson's realm, or is that too nuanced, I suppose?
Yeah, so Neuralink is basically for folks that are thinking about it. This is one of Elon Musk's companies. They're making devices to record out of huge numbers of brain cells. Okay, all in real time. And the idea is that maybe at some point you can have the brain cells communicating directly, maybe even through the air, with devices and things like that. Newsflash, everybody, we can already do that. Okay, it's a newsflash. Okay, and so we, so I think that we have to kind of take some stock and realize there have been a lot of people in this field, and I think one of the things that Elon Musk is challenging his engineers to do, and Flip Sabes at UCSF when he worked in with that company, they're greatly expanding and doing great work on expanding the amount of capacity of how many neurons, how many things, how big these devices are, how much network they can do, the capacities of the actual devices. But in the end of the day, in Parkinson's disease specifically, whether that will be as helpful as actually getting to the why, okay, understanding the why. Remember we talked about the why, like why are you getting, and targeting specifically within circuits, which is where DBS has been so successful. So certainly we welcome the idea of Neuralink bringing more hardware in, and but just in terms of game changers, I think we're thinking in a little bit different terms, because that's sort of a hardware advance that of a what, rather than a why, that might help to move some of the therapies forward. But that's really not our roadblock kind of at the moment. And the other thing is that as we implant devices, and even with DBS, and Dr. Foote and I had a YouTube many years ago in 2015 for a TEDx talk, and we start the talk by saying, well, one, we did it together, which was kind of, a unique thing for having two people on the TED talk, on the TED stage together. And one of us says, your brain controls everything, and the other person says, and we can control your brain. Okay, and we go through this whole exercise, and it's so fun. And we show a bunch of people that we've operated on, and we are, really trying to to think through, kind of what would be kind of the generation of what's going to happen. And then as things get more and more complicated, then we start to show, oh, we can create neuropsychiatric changes. We've operated on people, and we can make them smile on one side of the face. And if you know all the different areas of the brain, we serendipitously discover all of these things. And then you begin to say, wait a minute, these guys can change how you're thinking, can change your emotions and everything. That should make you feel uncomfortable, okay? And it should. And that's why we have to have an ethical underlying principle, which was what that whole TED Talk was about. The ethical underlying principle for us is that, we should only do things that alleviate human suffering, okay? And people are going to implant devices. Remember, plastic surgery didn't start, as a field that, where we're going to, change people's, appearances and aesthetics. It was because doctors were giving people mercury and destroying their noses, and they needed to reconstruct their noses. Okay, doctors. Okay, and we also had burn victims, and then slowly but surely safety, other things came, and now people think it's a right, to have plastic surgery in some countries. And so it's going to happen where people are going to put these large arrays within the brain, multiple companies, not just Neurolink. And one of the things we have is a DBS think tank, and as part of that think tank, we bring together leading experts every year. We've been doing it now for like 12 years, publish up proceedings. We always have ethical sessions there, and it's going to be important that we keep our eyes on the technology to make sure we don't stray kind of off course. And when somebody goes off course, because they will, we all know people are going to go off course, that we can nudge them back onto track and think about the ethical types of questions about how we can change brain function, thinking function, emotional function, and things like that. And so it's really important that we're talking about and thinking about those things up front.
So, since you live close to Disneyland, I have a happy ending Disney question for you.
Okay.
Do you think there'll be realistically a cure for Parkinson's ever?
Great question. So, I think the C word for Parkinson is overused, particularly with people who are trying to raise money for research. People promise, for the last 20 years, I've seen, 20 years plus, I've seen people say, oh, give me a whole bunch of money, and in 5 years, I'm going to give you a cure. Okay. Well, where's that cure? Okay. And so I think that we have to be really careful not to mix up the complexity of Parkinson with, something that might be, like a single problem in the blood, or something that we could put our fingers on and say, oh, we see that, we completely understand that, now we can design it. Oh, hey, we did that with polio, right? Hey, we have kind of done that with HIV. We shifted it from, an unlivable condition when I was an intern, in medicine, where we had wards full of people that if you had HIV or AIDS, it was like a death sentence. It was like the end of the world. Who didn't want to touch you. I mean, it was an incredible era. Now you see how treatable it is. See Magic Johnson at the World Series game here just recently, and 30 years in, and so, to me, I don't think of it in those terms. I think of it more in an Eastern medicine term. So Western medicine, Mike, we like to sort of fix everything and cure everything, right? It's like men, we're always trying to fix our marriages, right? We try to fix everything, right? Eastern medicine is all about healing. Medicine, Western, Eastern, healing, the person. We're all on a journey. We're all going to live a certain amount of time. The greatest change that we have had in the world, the greatest innovation in the last 100 years is the more than doubling of the lifespan, okay, since the 1850s, last 150 years. So we're doing pretty good, we're doing pretty good. I mean, pretty amazing if you think about it. What we need to do is we need to live better. And if we're going to live longer, we need to have better health span. We need to kind of live better with the diseases. It turns out now with Parkinson, we've developed so many great treatments that many people can live better lives despite having Parkinson's disease, okay? And I think that is a wonderful, wonderful thing. I think that we have to be careful, of being sort of blinded by the cure. I also think we have to be super careful about paying attention to the people who have the diseases. Okay, the millions and millions of people worldwide who have Parkinson's disease, who spend all this money, for the stem cell cure 20 years ago promising it. It's not there. We've got to spend some money, some proportionate amount of money on those people. We've got to spend a proportionate amount of money on preventing. The best treatment, Mike, is prevention. The best cure would be prevention, right? What if we could prevent people from getting it with pesticides and other things, and still develop along the road and take our victories. And maybe our victories will come on some of the genetic abnormalities first, with some gene editing and some other gene therapies, or some really innovative nanomedicine is something I'm very interested in as we begin to think toward that third or fourth frontier in the future. But I'm very optimistic, and we're making great progress. But I don't want to overpromise people in a disease that is this complicated, and I don't want to forget, we must lift the living of the people who have Parkinson's.
Okay, so if someone was recently diagnosed with Parkinson's, what are some good resources or places they can go?
Yeah, so if you're recently diagnosed, there's just so many, great places to go. First, you should join the PD Avengers. Okay, this is a grassroots group of like 8 or 10,000 people already and growing. These are the people that want to create the change for tomorrow for everyone, as a group. And so I think that's a great resource. In terms of things, I'm biased because I've been the medical director and advisor for the Parkinson Foundation, one of the best grassroots organizations. There are over 50 centers of excellence all over the world and care centers and everything. Parkinson's Foundation is amazing. The Michael J. Fox Foundation, just an incredible organization that's done so much for raising funds, pushing the research agenda, training agenda, and really changing, how we look at Parkinson. In the United States, Davis Phinney Foundation is fantastic. The APDA, the American Parkinson's Disease Association. So lots of things that we think about when we think about U.S. centric. But remember, U.S. isn't the only country in the world. When an airliner disappears, there's a lot of countries looking for that, for that answer. There's actually quite a number of people all over the world. And so if you look, Parkinson's UK, Parkinson's Europe, Parkinson's Australia, Parkinson's for almost any country, fill in the Mad Lib, Parkinson, that particular country. And then other diseases disease foundations have popped up too along the road. National Institutes of Health has a lot of great information as well as research. They are the single largest funder of medical research in the world. This is one of the greatest organizations for changing diseases and disease courses that we have. And so I would be remiss not to say that people should look toward that. And if you're looking for a clinical trial, look at clinicaltrials.gov, clinicaltrials.gov. That's where people register their trials. But just because you register a trial doesn't mean that you might not be up to something, or might be, there might be some shenanigans and it might not be a legitimate trial. So you can see all the trials that are registered, but make sure you talk to your medical professional. Call the Parkinson's Foundation. We have a free 1-800 helpline, 1-800, the number 4PD-info. For those of you old enough to realize that the numbers on your telephone also have letters that can spell out. So 1-800-4PD-info. It's a free helpline, and we have all sorts of trained multidisciplinary specialists. I met with them today. We meet every month to go over the most difficult questions, and we take any question from anyone, anytime on Parkinson, and they can also help to connect you with resources. But we're so grateful, and there can't be enough, so if you're going to make an organization to help with Parkinson, go for it. We need all the help that we can get. We need as many people walking that road with us. And remember, there were no roads until somebody walked on them. And so come walk on the road with us, and we would love it.
Well, thank you for joining me today. Would you mind mentioning the name of your book and where you work again?
Sure. So our book that's out is called Ending Parkinson's Disease: A Prescription for Action. If you're looking for a book on things that you can do and tips, I also wrote Parkinson's Treatment: 10 Secrets to a Happier Life. That was a runaway bestseller many years ago that people still love that book, and Living with Parkinson's Disease. And then watch out for our new sequel book to Ending Parkinson's Disease that will come out here in the summer of 2025. And I work at the Norman Fixel Institute for Neurological Diseases, and grateful to the University of Florida and to the Institute for having me here for so many years, and Kelly Foote for co-founding that institute with me.
Well, thank you for joining me. I learned a lot, and don't ask me to recite half of it, though.
Well, you all you have to worry about, Mike, is that in 5 years, half of everything that we spew is going to be either updated or changed. And so every day I practice medicine, I know a little less. And these days I say every day I practice medicine, I know a lot less. And so I think we have to be humbled and we have to listen and then just try to do what we can. And just one thing to leave people with: we must lift the living, the people who have Parkinson's disease now, and on the journey we can't forget them, while we're reaching for cures and reaching for better treatments. We all want that, but let's not forget the people who have Parkinson's.